So I'd like to discuss this assessment and disposition algorithm and tool for patients presenting for assessment for closed head injury. And while this is ski patrol specific, certainly it could be used by anybody who has to do non-emergency department based assessment of patients with closed head injuries. This starts with the obvious, which is that if the patient's unconscious or if they have severe life-threatening injuries, including injuries not related to the closed head injury, then you need to evacuate them. They're not patients that you can take care of in a ski patrol hut. So call for EMS, consider helicopter EMS if that's part of your algorithm or part of your protocols for evacuating these patients, but stabilize them as best you can and get rid of them. If they're not unconscious or they don't have obvious severe life-threatening injuries, then the next thing that we're thinking about is, does the patient have any indications of significant intracranial injury? That is a neurosurgical emergency like a subdural hematoma, an epidural hematoma, traumatic subarachnoid hemorrhage, even interparenchymal bleeds. And so we assess them now for those findings. So any patient who has a loss of consciousness for greater than 30 seconds, a severe headache, and I realize that's a subjective definition, but if the patient says the headache is severe, it's the worst headache they've ever had, or they look very uncomfortable with it, consider it severe. They've had 2 or more episodes of vomiting. They have on your exam a suspected open or a depressed skull fracture. There's injuries to the head consistent with that. They have any sign of a basilar skull fracture, so raccoon's eyes or battle signs or cerebrospinal fluid leaking from the nose or ears. They're older than 65. They're on any anticoagulation medications. And you really need to even consider aspirin as potentially falling into this group, as it does cause quite a bit of platelet inhibition, and patients on aspirin can have significant ongoing bleeding, particularly intracranial bleeding. Or the patient had a seizure at any time after the closed head injury. Those are all findings that make us concerned, fairly concerned about the possibility of intracranial hemorrhage. And so for that group, you want to transfer them to the emergency department where they'll at least get another assessment and may very well get a CAT scan to look for that hemorrhage. You want them to go by EMS, and that's because if they have an intracranial hemorrhage and it gets worse, they could have a seizure, they could become unresponsive, they could die. And it would be much better for them to become unresponsive being cared for by EMS providers than, say, driving their own car or being in the car with someone else, because that person won't be able to take care of them. So if they refuse to go by EMS, and if they have capacity to make that refusal, which they may not with a closed head injury, but if you assess them as having capacity to refuse care and they don't want to go by EMS, but they have one of those findings that makes you worry about intracranial hemorrhage, then you should document that as against medical advice and use whatever forms your patrol uses as appropriate. But suppose they don't have any findings that make you worried about intracranial hemorrhage. Well, then we want to assess them for signs and symptoms that make us think about a concussion. And we'll talk about why, when we talk about disposition, it's so important to identify patients with these concussion findings. But we're looking for signs, things that observers, people skiing with that person, or if they were a racer, the racing staff report to you, and anything the patient reports to you, their symptoms. So signs include appearing dazed or confused. They are very confused about following instructions. They forget how to put on their equipment or how to take it off. They're moving clumsily. They answer questions very slowly. They have any loss of consciousness that was observed, even for a few seconds. So this isn't the greater than 30 seconds we talk about when we're worried about that intracranial hemorrhage. This is out for 5 seconds, completely unresponsive. That's still important. Any behavior or personality change, they forget events prior to the accident or they forget the events after the accident, and that's, again, observers telling you that that's what was going on when they were first with the patient. Those are all concerning for concussion. Now, the patient reports any headache, nausea, balance problems or feeling dizzy, off balance, vision changes including double or fuzzy vision, light sensitivity or noise sensitivity, a feeling of being very slow or sluggish, or feeling very foggy, like they're in a daze or in a fog and they can't really get a good grasp of what's going on, changes in their sleep patterns. And these can sometimes be patients, particularly at large resorts, they hit their head a day or two later, they're not thinking they feel quite right, so they come in for an assessment. And so you want to know, are you sleeping a lot more than usual? Are you sleeping less than usual? And any concentration or memory problems that the patient observes. Now, if the patient or the observers volunteer this information to you, you say, tell me what happened, tell me what's going on, and they tell you these things, great. But if they don't, it's important to go through and ask individually about each of these, because you really want to make sure that you pick up any of these signs or symptoms. And sometimes they're not going to think to tell you because they don't think they're relevant. So ask very specifically about them, unless they give you a report of any of these signs and symptoms, in which case you've already figured out your disposition. So these are all findings that we would expect to see with a concussion. And one of the big problems with concussion is what's known as a second hit syndrome, where somebody who has a concussion and has concussion symptoms goes out and suffers another closed head injury with a second concussion. And these can be very minor head traumas, but they can lead to long-term disability or impairment. And so for these patients with any of these symptoms, we don't want them to return to any activity where they might get another head injury. Offer them EMS transport. So it's not mandatory the way that it would be when you think there's a significant intracranial hemorrhage or a neurosurgical emergency, but certainly offer them EMS transport. They need to be seen that day by an appropriate practitioner, whether that be their primary care provider or a walk-in care or an emergency department. Any of those is fine. They just need someone with an advanced level of training, a physician, a nurse practitioner, a physician's assistant, to assess them to determine if in fact maybe there's more going on, which would require them to be evaluated for intracranial hemorrhage, that is, to get a CAT scan, or at a minimum to establish a baseline so that if they have ongoing symptoms, there's documentation of their initial evaluation by one of these advanced medical providers. But suppose the patient doesn't have any of those signs or symptoms. Well, now we need to actually do some cognitive testing on the patient. So for cognitive testing, we are actively testing them for their thinking. And in two of the domains, orientation and retrograde amnesia, your testing depends on the fact that at baseline, without an injury, the patient would have certain knowledge. So as best as you can, ask observers, ask the patient if in fact they would normally know the correct answers to the questions. Because if they normally wouldn't, I mean, think about it. You're a big ski area, you got someone who's never been there before, and they fall and they hit their head, and you ask them, well, what trail were you on? They may have no idea at all because they've never been on it before. And that doesn't mean that they have retrograde amnesia, it just means they didn't know what trail they were on. So you need to be able to sort that out to a certain degree. So start with orientation. What ski area is this? What month is it? What city or town is this? Where are we? What day is it? And were you skiing or riding, or were you in the tubing park? Were you hiking up the side of the trail and got nailed by somebody? And you may be able to, by their gear, figure out what they were doing, but it's good to assess that. You want to assess their concentration, so repeat the days of the week backwards, starting with whatever day it is. So start with today and go backwards, and then repeat the following numbers backwards, 63 and 419. Now, you're listening to them and assessing them, and so it can be sometimes hard for you to figure out what the correct answer is. So they're included on this tool. So 63 backwards is 36, 419 backwards is 914. So just make it a little easier on yourself so you don't have to sit there trying to figure them out too. You want to assess for amnesia. You want to assess for retrograde amnesia and anterograde amnesia. So for retrograde amnesia, who drove you to the mountain? What do you remember just before the accident? What trail were you on when the accident occurred, and do you remember the accident? That all gives you information about what they recall immediately around the accident, and also back to is earlier in the day or whenever it was they arrived with the question about who drove you to the mountains. So you get some sense of their memory before the accident, and then you also assess their memory after the accident, and you may be able to get some of this information talking to the patient and observers. But a formal way of testing this is to have the patient repeat 3 words to you and give them all 3 words, because you want them to have to remember all 3 words, and then have them repeat all 3 of them back to you, not one at a time. So girl, dog, and green are completely unrelated words, and so say to the patient, I'm going to give you 3 words. I want you to repeat them back to me. Girl, dog, and green. Okay, now go ahead and repeat those back to me. And if you want to do more formal testing, you could even ask them again at 5 minutes. So you're doing some other things and then go back and say, do you remember those? But for the purposes of this evaluation, if they remember all 3 of them right after you ask them, then they pass. And if they don't remember all 3, then they failed cognitive testing. So any findings in here suggest a concussion. So you don't want them to return to activity. Again, you're trying to avoid that second hit. They do need a same-day checkup with an appropriate provider, be it at a primary care, walk-in care, or an emergency department. Totally up to the patient. They have findings that suggest a concussion. They need more formal testing. That's all we're telling them. You don't think they've got a neurosurgical emergency. You really don't need to offer them EMS unless that's your mountain's protocol to do that. So basically, make it clear to them, don't go out and do anything where you might get another head injury, because that could cause permanent disability for you, and you need to be checked by someone with a more advanced level or scope than I have as a patroller today, and make sure they understand that. If they don't have any findings that make you think about a closed head injury, a concussion, they're completely asymptomatic, the closed head injury, well, you're not necessarily done at that point. So this is not going to be uncommon for you. You're going to have the parent who said, you know, my kid took a big hit and whacked his head and seems fine, but can you check him out? So you go through and there's no signs of severe intracranial hemorrhage, and they don't describe any signs, and the patient doesn't have any symptoms that are concerning, and they fly through the cognitive testing. Well, what that means is at that moment, there's no sign of a closed head injury. You also need to assess them to make sure they don't have other injuries that need to be addressed. Obviously, none of them were life-threatening, or you would have transferred them out earlier. But you know, took a fall, hit my head, I think I broke my arm. You look, they've got what looks like a lot of radius tenderness, and you put them into a splint. You have someone take them to the local emergency department, or they have what looks like a tib-fib fracture, and so you call EMS to transport them. You have to address those other issues. But if they don't have any other injuries, and they're asymptomatic of their closed head injury, they're just asymptomatic right now, which means they can return to activity. They've got nothing to suggest a concussion. They need a follow-up in 24 to 48 hours with an appropriate provider. Again, primary care provider, walk-in care, emergency department, whomever. But they need to be checked in that time period. And you need to discharge them with closed head injury instructions that basically give them a description of things that would be concerning, and reasons to seek care sooner, and in particular reasons to seek care in an emergency department. So things that would be suggestive of the acute intracranial hemorrhage with a neurosurgical emergency that we discussed earlier. So make sure that all patients that you are discharging, that you are not sending by ambulance, have closed head injury instructions, even asymptomatic patients. They need to have those so that you assure that they've got good understanding that you just did a screening evaluation, and at that moment in time it didn't look like they had any symptoms. So based on this, you should be able to assess and disposition patients with closed head injuries with some practice, you should be able to get through this screening in less than 5 minutes. But again, make sure that unless the patient or observers volunteer a positive, so you clearly have your disposition, make sure that you assess specifically every piece of the algorithm to make sure you're not missing anything, because patients just don't know necessarily what the important information is that they need to give you.